So we're going to talk about microlaryngoscopic and office surgical treatment of benign vocal fold lesions today. What we'll do is review the anatomy and histology. We'll talk about the evaluation and some special considerations. We'll go through some of the important aspects of the stroboscopic interpretation. And then we'll talk about management, a little bit about medical, but mostly about surgical. We'll talk about both operative in the operating room, as well as office laryngeal laser surgery. Various indications and techniques for both. So this is just an example of the histology of the vocal fold here. False vocal fold is up here. This is the laryngeal ventricle. And then here's the true vocal fold. And we'll focus on what this ultrastructural analysis is, so that we can go through the various layers, because this plays a role in the techniques that we use today to remove some of these lesions. So here's an example of a cross-section of the vocal fold. And what we see is this purple is the epithelium. And at the base of the epithelium, obviously, is the basement membrane zone. And then we have the lamina propria. And the lamina propria of the vocal fold is divided into 3 layers. There's the superficial layer of the lamina propria, which is this region here. The intermediate and deep layers of the vocal fold make up the vocal ligament, which is this darkly stained structure here. And then we have the vocalis muscle right here. So when we think about the way the vocal folds vibrate, the cover of the vocal fold, which is comprised of the epithelium, basement membrane zone, and superficial layer of the lamina propria. And then we talk about the transition zone, which is this intermediate and deep layers of the lamina propria, or vocal ligament, and then the body. This is sort of a gelatinous layer here, and this is what vibrates differentially from these 2 structures. So this is the body, and this is the cover, as classically described by Dr. Hirano. And this leads to a lot of our techniques that we use to today, understanding the function of the vocal fold. Well, why do these benign lesions of the vocal fold occur? Well, they're non-neoplastic, and essentially they're all a response to injury, and they all occur within the cover of the vocal fold. And when they do that, they disrupt the vibration, and they also affect vocal fold closure or glottic closure. So they stiffen the vocal fold, which has to be pliable in order to produce voice, and they also affect the closure. There's various forms of vocal fold injury. It can happen from inefficient voice use, talking without good breath support, without good resonance, straining the vocal fold and the throat muscles. Voice overuse. A lot of professional voice users, singers, actors, teachers, they're essentially vocal athletes. And just like any athletic use of the body, it's prone to injury. Various infections. All kinds of chronic irritation from allergies, affecting the resonance cavity, causing postnasal drainage and thick mucus on the vocal folds, leading to throat clearing. Reflux, if it can go from the stomach to the esophagus, it can cross the upper esophageal sphincter and affect the vocal folds and the larynx itself, causing inflammation. Asthma is kind of a double whammy because it affects the breath support, which is the power for the voice. And a lot of the inhalers, such as steroid inhalers, the dry powdered forms like Advair in particular, can cause a yeast infection or a fungal laryngitis. Sinusitis, again, affecting the resonance cavity and causing thick drainage. Obviously tobacco and alcohol. And the quality of the mucus is very important. When the mucus is too thick, the phonation threshold pressure increases, and that puts too much tension and strain on the vocal folds and can lead to injury. So assessing how much water and caffeine somebody drinks is important. Other important considerations in the history include how long this problem has been going on. Is this a chronic problem? Is this an acute problem? Is it intermittent? Come and go? And I always teach that it's important to try and differentiate hoarseness. Is it raspy? Is it breathy? Do you hear 2 tones or diplophonia? The quality of the voice that you hear can lead you down different differential pathways. How stable are the symptoms? Can somebody get a normal voice at times, or are they always having chronic hoarseness? If they are a teacher or somebody who needs their voice for their occupation, how is it affecting their work function? Can they maintain their performance or work schedule? If they can't, then that's more of a serious functional limitation than somebody who can. We obviously have to think about the whole person, and we have to assess associated medical factors such as reflux, allergies, sinus disease, pulmonary disease. There are obviously rheumatologic factors as well and other conditions that can affect vocal function. So when we do an examination in these patients, we want to do a general examination. We want to do a full head and neck examination. We want to pay special attention to the sinonasal cavity, conditions of the oral cavity, Is there decreased tongue motion? Is there velopharyngeal weakness? Obviously, the hallmark is looking at the laryngeal examination, both the mucosa, the function of the vocal folds, closure, vibration, and the mucus consistency. So what are we doing? Well, we're going to do a voice recording. The perceptual voice analysis, how they sound, is very important. We're going to do a laryngoscopy, and there's various techniques using rigid and flexible instrumentation. And when we're considering surgery, it's very important to get a video stroboscopy. This allows good, documented interval examination, allows for observation of additional pathology that you might not see with typical halogen light, allows you to assess vibration and viscosity of the vocal folds, which is very important because you're going to be working with that layered microstructure, and this is the best way to assess that layered microstructure. The key part about stroboscopy is that it allows you to assess the vibratory patterns, and you can do that at various pitches. Certain subtle lesions you may not see at a low pitch or a modal frequency. When you elevate the pitch and the vocal fold stretches, you can see subtle lesions that you cannot assess otherwise along that medial edge. And really, again, if we think about the cover body theory and how vibration works, this allows us to assess the viscosity of that color of the cover and allows us to really assess a vocal fold closure. So why should we do this? Well, if you have somebody who has problems with their voice and their complaints do not seem to be consistent with a mirror or a halogen examination, then you need to assess with more detail to assess that ultrastructure. We want to be able to document the vibratory patterns, the mucosal pliability, and really assess the quality of that layered microstructure of the vocal fold. You can also assess the undersurface of the vocal fold with stroboscopy, that inferior leading edge. And you want to document what these vibratory patterns are and difficulties are prior to any intervention. Somebody who really needs their voice professionally for their occupation, you want to consider doing this earlier than later so you can assess subtle defects and problems before they become more severe. If somebody has subtle voice complaints such as fatigue, or if they're a singer and have isolated loss of upper range, you're going to have a very hard time seeing that without being able to have the ability of video stroboscopy. If somebody has difficulty going from their low pitch to their high pitch, that's a very complicated area where you have interactions of different muscles, and again, best assessed with stroboscopy. So let's go through some various lesions and talk about the various types, where they occur, and how we can address them. And this is just an example of some of the lesions that we're going to talk about. You see a very large cyst over here and a more polyp-like lesion over here on the left vocal fold. So what's a vocal fold nodule? Well, if we look at a vocal fold nodule, we're going to see typically symmetric lesions in the mid aspect of the vocal fold. Why the mid aspect? Well, this is where most of the vibratory action occurs and most of the frictional forces occur, is in this location of the vocal fold. The way I explain this to patients is this is essentially a callus. You can see with these lesions here that when the vocal folds come together towards the midline, they're going to touch here first and have what we call an hourglass closure, as opposed to a complete closure with straight edges along the vocal fold. The edge of the vocal fold should be along a plane just like this on each side. What we see ultrastructurally is we see the thickening of the epithelium, and we see increased deposition of various proteins, typically collagen, but also fibronectin and other extracellular matrix proteins, and thickening in this basement membrane zone and in the superficial lamina propria. And you can imagine that when the vocal folds go to vibrate, that this is now a thickened area, has increased scar, it's not going to vibrate as well. So we have a problem with both closure and vibration affecting the voice. Polyps come in a variety of different types. This is a classic hemorrhagic polyp over here. Typically starts with rupture of a blood vessel, and you get a lesion that develops, and that lesion then continues to bleed and become fibrotic, and you have a big lesion like this. Obviously, this is going to get in the way of vocal fold closure, and it's going to affect vibration. This type of polyp ultrastructurally would be represented by this slide over here, where you can see that you have this protuberance of tissue, fibrotic, often somewhat vascular lamina propria, affecting the edge of the vocal fold. Polyps can be more sessile-like and broad-based, as demonstrated in this picture here, but still has a similar effect affecting vibration and vocal fold closure. This is an example of a vocal fold cyst. You can see this bulge here, and you can see this sort of a yellowish hue around this lesion. What you can't appreciate is how deep this lesion goes into the vocal fold here. It does not end here. Typically these lesions extend all the way down to the vocal ligament. What you can see then is that there's this invagination. It can be a mucus retention cyst. This is a depiction of an epithelial line cyst, as in this gross examination over here. And these cause significant vocal fold stiffness because, as you can see, there is no lamina propria in this area. It's been replaced by this cyst. And so you have the vocal ligament in the muscle, the body of the vocal fold, essentially attached to the cover. So there's no vibration. There will be vibration anterior and posterior to this lesion, but not in the vicinity of the lesion. Because it also has a mass effect, it will also affect the closure of the vocal folds. This is one of the worst things that I can see, and this is essentially a fibrous mass. In contrast to this picture, where there is a well-defined cyst wall, when you have a fibrous mass, you have thickening throughout that lamina propria, and it's very difficult to determine what's normal and what's not normal when working with one of these lesions. It's also hard to differentiate the scarring that's abnormal in the lamina propria between the vocal and the vocal ligament itself. So this is a very difficult problem to treat, and you can see just how regular these edges are, and there's no vibration. Vocal fold varices are another type of injury that can occur to the vocal fold, and these lesions become essentially a dilated blood vessel, and they occur from trauma. Blood vessels are normal within the vocal fold, but they should be thin, and they should not be thick and dilated like this. We should not see them in this manner. You can see a small one over here, a large feeding vessel here, but in particular you can see this very large vessel over here. Sometimes these varices, because they're so dilated, can have a mass effect itself and affect closure and vibration. This is also a risk factor for somebody developing a hemorrhage in the vocal fold. So when you see this, it's important to counsel a patient about aspirin and ibuprofen products, and even certain homeopathic medications such as taking lots of supplements with garlic, ginkgo, ginseng, or ginger. So I always have that conversation, and if the patient ever, who I know has this, presents with a sudden change in their voice, they need immediate attention to make sure that that vessel didn't rupture, causing a vocal fold hemorrhage, because that's a voice emergency to prevent further bleeding and complications. Another difficult problem to treat is what we call a vocal fold sulcus. So if you see here, you can see this grooving along the vocal fold grossly on this left-hand side. And there's also a groove that you can see along the right-hand side with this lesion along the inferior lip of that vocal fold. What that looks like in the region of a sulcus, if I did a cross-section right through here, is again we have our epithelium, we have our lamina propria, vocal ligament, and muscle, but in the region of the sulcus, we don't have any lamina propria. And there's various types of sulci depending on how deep this groove is. They can extend just into the lamina propria where there's still a little bit. They can extend down to the vocal ligament, as in this case, and sometimes even invaginate a little bit into the vocal ligament. These cause significant problems with closure because you've lost some of the medial edge, and they also cause significant problems with vibration, similar to the cyst, because in this location there is no vibratory portion of the vocal fold. So what do we do? The most important thing is that all voice users should be treated equally. Whether you're a singer, whether you're a teacher, whether you're a computer scientist, it doesn't matter. If it's affecting your function, then they need to be addressed. What are our management options? I know we're going to focus on surgical treatment, but a good surgeon also evaluates and manages the patient completely. So we want to treat associated factors, such as allergies, reflux. Vocal fold hygiene refers to how much water, caffeine, and other behaviors that you can address, such as throat clearing, yelling, things that you know are traumatic to the voice, to try and quell those to improve their voice by itself, and will also improve your post-operative results. If somebody's taking lots of cough drops, that's also important to inquire about, as things such as menthol, eucalyptus, and mint can dry out the mucous membranes. And again, dry mucous membranes have more pressure on the vocal folds to cause vibration, which can cause more injury. You want to look at their medications. If they're on a dry powdered inhaler, talk with your pulmonology colleagues and see if you can get them on an HFA version or a different type of inhaler to decrease irritation from the dry powder inhalers and possible fungal laryngitis. I feel it's very important to do this in a multidisciplinary fashion when you're evaluating these patients, and I work very closely with speech pathology colleagues to address many of the behavioral components which are important to start decreasing preoperatively and will be essential to treat postoperatively to maximize results. And then obviously surgery is important. So when do we think about surgery? Before we get there, I do want to again highlight why a multidisciplinary evaluation is important. They truly are a partner in managing the dysphonic patient. And because there's lots of behavioral components, the patient is a key player in getting better. And what we want to do with the speech pathology evaluation is assess how voice use itself have an impact on the complaints of the voice regardless of the lesion. We've done studies to look at which lesions need surgery and which ones don't. Some people who have lesions can benefit from voice therapy. And this is required, in my hands, prior to anybody who's going to get surgical intervention for one of these non-neoplastic laryngeal lesions. So when do we think about surgery? Well, when the quality of life is affected. This is a functional problem. So if somebody cannot function to the abilities that they need with communication, with work, with social life, feeling isolated, all of those things are important to consider. I always try medical and behavioral modifications, and if they have failed despite good patient compliance, then that's a telling sign that that lesion is problematic enough from a vibratory and closure standpoint that it needs to be removed in order to improve function. In particular, if you're a professional voice user or a singer, if you cannot perform to the desired level, you can't meet needs, if you're having to get substitute teachers often, then something needs to be done to help you function. So if a schedule cannot be maintained, that's an indicator that that lesion is having a functional impact in your life. Informed consent is very important when you're talking about this. Things that are essential to discuss is that even though you're trying to improve somebody's voice with a surgical treatment, there's always a risk of having permanent hoarseness. You are making incisions on the vocal fold. The body cannot regenerate the lamina propria. And at the moment, even though there's exciting research being performed, we cannot replace the lamina propria. So a careful assessment and a careful discussion of risk factors is important. If somebody's a singer, there is a risk of losing the singing voice. And I tell people that rehabilitation, again, depending on the nature of the lesion, how large, its impact on closure and vibration, can range anywhere from 2 to 4 months before they are kind of turned loose from therapy. And I give them the analogy of knee surgery. If you had knee surgery, you would have to do physical therapy afterwards to get your range of motion back and to build up your strength. And surgery in the vocal fold is no different. So what are our goals? Obviously, our goal is to optimize the voice outcome. We want to minimize any injury to the normal tissue. And essentially, from a functional standpoint, we want to restore normal edge to the vocal fold and restore normal vocal fold vibratory pattern. So when we are doing this, we have to remember that the abnormality is primarily within that superficial layer of the lamina propria. Vocal fold stripping techniques remove the overlying epithelium and portions of that lamina propria. All we want to remove is the diseased portion, preserving as much of the normal anatomy and redraping that normal anatomy as possible to have the best edge to the vocal fold and best ability to vibrate. So our surgical principles are we want to be minimally disruptive. We only want to remove the diseased tissue. We have to preserve the uninvolved structures that are surrounding us, the lamina propria, the vocal ligament, and the epithelium. And we want to restore the laryngeal configuration. And we have to have a three-dimensional appreciation of what that configuration is when we're working under the microscope to do this. There are various techniques that can be used, and we're going to go over some of these. Cold instrumentation, laser instrumentation, and there's also powered non-laser instrumentation. Well, let's think again about our vocal fold. We have the epithelium, we have the superficial lamina propria, we have the vocal ligament, this, again, darker area that is adjacent to the muscle. The CO2 laser is commonly used in airway surgery, but all lasers have an area of thermal damage. It's 25 to 200 microns, depending on the mode of the laser that you're using. And so this is a representation of the various zones of injury that can occur. And you can see, depending on your modality of use, you can have injury into the lamina propria and even extending down into the vocal ligament. And with the lamina propria being roughly 400 microns, You have to be very judicious in how you're using the CO2 laser, because they can risk injury to the epithelium that's overlying, as well as portions of the lamina propria and even the vocal ligament if you're not careful. I think the preferred technique with these lesions that I've demonstrated so far is what we call a microflap excision. And this is based on the histopathology of where these lesions occur, which is right here within this lamina propria of the superficial layer. These techniques spare the epithelium that's overlying, and they create a plane demonstrated by this dashed line here that occur within the lamina propria. We want to preserve the vocal ligament that's deep to that, and the normal lamina propria that's around this lesion, as well as the overlying flap. So if you make an incision through here, then you can imagine that there is a pedicled flap of epithelium and lamina propria that's based in this location. We can get into this area, remove what's here, and then re-drape this area back down. So again, the key principles of a microflap technique are we make a mucosal incision. You want to identify the vocal ligament because you do not want to injure that. Then you'll have scarring within your lamina propria, scarring the cover of the vocal fold to the body of the vocal fold, and that's going to affect your vibration postoperatively. The key is then to create this plane superficially within that superficial layer of the lamina propria. One consideration is, well, where do I place that incision? There are various places to place that depending on the nature of the disease that you're talking about. You can make a lateral incision, lateral to the lesion, or you can make a medial incision, medial, right next to that lesion. Well, if you have a reduced or absent mucosal wave and you think that that lesion is adherent to the vocal ligament, when you palpate and assess this under the microscope, which is absolutely vital before you make any incisions, is take a blunt probe, use a small suction, and assess the nature of the lesion, how it feels, its adherence to the overlying epithelium, and any appreciation of the vocal ligament. You can use a little suction and you can try and suck the lesion off the vocal ligament, and if it comes, then it's not attached. If it's adherent to that, then there is some scarring in that region. You want to get a sense, is there discrete borders or is it more indiscrete borders, and you can assess that again by palpation. If you have problems that you're concerned about wave, and you know that preoperatively from your video stroboscopy assessment, you're concerned whether that's attached to the ligament, then a more laterally based lesion is important, so you can identify normal superficial lamina propria anteriorly and posteriorly to the lesion, as well as identify your vocal ligament, so you can go from healthy known, work your way towards unknown diseased area. If your mucosal wave is more intact, if the lesion is more along the medial surface and seems to be easily separated from the vocal ligament, then you want to make an incision that we call a medially based incision, which is right next to that lesion. If you make your incision more laterally, you're going to have to go dissect through a lot more normal tissue, and again, our goal is to disrupt as least amount of normal tissue as possible to get the best results. So let's go through an example here, and this is an example of a laterally based lesion. This is a picture again of that patient who has the vocal fold cyst. This is just a cottonoid that is overlying the endotracheal tube. And here you can see the cyst. You can see the mucosa tented here and here. But when you palpate this and you're looking under the microscope, you can get a sense that this is just mucosal tenting because the lesion is this little yellowish ball sitting right here. But I cannot see where it's attached to the vocal ligament. I know from my preoperative assessment that this is very stiff. So I'm going to make an incision more laterally, and you can see the sickle knife right here, so I can try and identify normal lamina propria in this region as well as here, and identify my vocal ligament. After I make my incision, then I have a little elevator, which you can see here, and it's got a little 90-degree angle on it, so I've made a mucosal incision right along this pathway, and then we can get into that superficial lamina propria. And you can see that it's not so distinct because I'm underneath the epithelial lining here. And I'm going to elevate this layer of epithelium and lamina propria up off the ligament and over this lesion. So here we are now working within the superficial layer of the lamina propria. And you can see that this cyst is well defined. Here's part of the wall right here. You can see here the margin is over here, and then here's the margin vocal ligament is going to be over in this location. Then using suctions and elevators, sometimes little scissors, you have to dissect the attachments of this cyst, trying to preserve the wall because you don't want to rupture this cyst. That will make it harder to define the cyst wall and get the whole lesion out, and will lead to an increased chance of recurrence. But we want to separate this cyst from our inferiorly based flap, which is tented right here, and separate that from the vocal ligament, which is at the base over here laterally. Once that cyst is then free, we can redrape this inferiorly based flap. You can see the incision that we made right here. We have a much preserved edge of the vocal fold compared to what we started with. Well, when should we make an incision that's more medially based? And here we make an incision essentially over the lesion, right at the base of the junction of the lesion and the normal vocal fold itself. We're still going to elevate the mucosal cover along the superior surface of the lesion. We're going to elevate that over a short distance of the vocal fold. We still have to separate the lesion from the normal lamina propria superficially, as well as the vocal ligament. This technique works very well for pedunculated lesions such as vocal fold polyps. Normal vocal fold here, and you can see where the true edge of the vocal fold should be. It's right along here. We're using a little alligator forceps to grab this polyp, which you can see in this fashion here. If I made an incision like I did in the cyst over here laterally, I would have to dissect through all of this normal tissue to get to the base of this lesion, which is located here medially along that inferior surface of the vocal fold. I don't want to do that because that will damage and cause stiffness in this location. So we make an incision along the medial edge. I get my little dissector in there again. Open up this area. This is just extending that incision a little bit more along the edge of that vocal fold. Freeing up this tissue. And I know that I'm going to have excess inferiorly based flap. I know that this polyp is filled with vascular gelatinous material, and I can tease that out, creating an inferiorly based flap, and then I can excise, as shown in this picture here, excess flap in that diseased lamina propria, so that I'm left with a straight line incision. You can see it's medially based compared to the last example I just showed of the cyst, and you can see that there's good mucosal coverage where this inferiorly flap, which is based pedicled right here, attaches to and approximates the superiorly based flap right here. And that's going to give you the best result. That would be in contrast to just grabbing this lesion and grabbing a scissors and cutting straight along this edge. You would not have this approximation and preservation of tissue. And this is all about mucosal preservation. Now there are times where your disease is the epithelium itself, where you cannot preserve that. This is an example of a patient who has leukoplakia. You can see a big lesion right here. You can see that he has an anterior glottic web, as we know that leukoplakic lesions can recur. So he's had multiple surgeries prior to seeing me, and because of the surgeries and having raw surfaces on each side of the vocal fold, has the scar band that now extends between the vocal folds, and more leukoplakia over here. So we're going to use a similar concept if we're going to remove it with a microflap excisional technique to what we did for benign disease. The issue with leukoplakia is that this could represent anything from mild dysplasia all the way to carcinoma in situ or a T1 vocal fold cancer. So we don't want to just take a little punch biopsy in this location, because that's not going to tell me anything about the pathology that's happening in this location. So we want to have a full excisional biopsy, preserving as much normal tissue as possible. So what you can do is make an incision lateral to the lesion, and this is going to be more scarred than in the prior examples because of its prior surgery, and you can get your elevators and your scissors, and you can get a sense as you're dissecting whether this is stuck, how scarred it is, do you need to make it a deeper plane, but you can remove this whole lesion and then have a complete pathologic evaluation of this lesion. What do we do after patients have had surgery? I put them on voice rest for 1 week to allow that mucosal flap to heal. I don't use any sutures. The surface tension of the saliva is usually enough to allow that mucosal flap to reapproximate and stay down. I tell patients if they get a cold, start coughing, that they need a calling, and I want to suppress that cough because that's traumatic to our healing flap. After 1 week, I see them back in clinic, and I start what we call graduated voice use over the next 2 weeks. The way that I do that is I have them talk 10 minutes on postoperative day 8. They get 20 minutes on postoperative day 9, and they double the amount of time they talk every single day. Starting in week 2, I have them start voice therapy as they're starting their graduated voice use. And I usually see them back at 1 month or 6 weeks, and then again at 3 months after their surgery to monitor their complete healing. You can consider adding anti-reflux medications. If somebody has allergies and postnasal drainage, I want to have that managed so they're not throat clearing, again because that would be traumatic to the vocal folds. And then we start the voice therapy. We've progressed, and now we can talk about office treatment for various lesions. Why the move to talk about office treatment and consider this in our patients? Well, it's minimally invasive. There's no sedation required. This is all done under local topical anesthesia, so we can avoid the morbidity of general anesthetic. The postoperative recovery from an anesthesia standpoint is avoided. There are studies that show that this is less costly than doing surgery in the operating room. Repeated procedures are more convenient because essentially it's a clinic appointment. Somebody comes to see me, we can treat them, and they can drive themselves home. There's good literature to show that this is well tolerated, and patients have a good response to this treatment. So what kind of lesions work well with office laryngeal laser surgery? So here's an example of somebody with, again, vocal fold leukoplakia. Now, I always like to have a pathologic diagnosis before I start treating these patients in the office. So this is an example of me taking him to the operating room, where again I'm going to use a microflap excision technique to make an incision laterally along this vocal fold. And that's the incision that you have to make. And then you're going to use your elevator to elevate all this area because this is all diseased. And you can see it extends even down into the subglottis here. And this gentleman wound up having severe dysplasia or carcinoma in situ. So if I just took a biopsy of this here, I would have missed potentially his disease. These lesions are recurrent, which is why we have moved to, after you have a pathologic diagnosis and understand the nature of somebody's disease, offering office laryngeal laser treatment. Otherwise, these patients get a lot of general anesthesia and recurrent operative procedures in the operating room. And this is less morbid and has less functional impact than going to the operating room. We know that patients who have leukoplakia can develop squamous cell carcinoma, and the rate of transformation, malignant transformation, depends on the degree of dysplasia, ranging from roughly 3.5% in somebody who has no dysplasia to 10% in somebody with mild moderate dysplasia, up to 18% in somebody with severe dysplasia. So I follow these patients indefinitely. I tell them that we're going to have to become friends because I have to monitor their disease. And when they have a recurrence, we can discuss whether we should go back to the operating room, whether I can remove this in the office. If we do try and remove it in the office and it doesn't respond, I go back to the operating room for a complete excisional biopsy to make sure that the pathology has not changed because we know that it can. Another disease that is treated very well in the office compared to the operating room is laryngeal papilloma, which we know caused by human papillomavirus 6 and 11. We know is recurrent. Some patients can have over 100 surgeries. That's very morbid, very costly to keep going to the operating room for that. We know that this disease can have a severe functional impact and that there's no cure. Now this is a child who has papilloma. You can see the endotracheal tube right here. This would not be a great candidate for an office procedure because this patient has airway compromise. Plus the patient is a child, intolerance would not work very well. So what are we talking about? What is office treatment? Well, we're removing disease on the vocal folds in the clinic in the awake, unsedated patient. And what we're doing is we're photocoagulating the subepithelial microcirculation. Leukoplakia is vascular, papilloma is very vascular, and I'll mention as well other lesions such as Ranke's edema or polypoid chorditis or other vascular polyps. Those all work well with treatment in the office. Well, I talked about the CO2 laser, and there are fiber-based ways of administering the CO2 laser in the office. But these lesions work very well with using what we call photoangiolytic lasers. Well, what are we talking about? There's the pulse dye laser, who has a wavelength of 585 nanometers. Most people, and myself as well, now are using the pulse KTP laser, which has a wavelength of 532 nanometers. The chromophore is oxyhemoglobin. These graphs show the curve, and you can see that the KTP, with its wavelength, we call that the green light laser, and when you use it, you'll see the fiber become green. The PDL laser, with a little bit longer wavelength, is in the yellow distribution. Well, if you look at the absorption, CO2 laser is absorbed by water. All tissues in the body have water. So if we use the CO2 laser for these lesions, it's not as selective as if we use this green light laser, which is absorbed by oxyhemoglobin. And if we can attack the microcirculation of these lesions can regress and be removed. And they're more selective. CO2 would affect the overlying epithelium because a lot of these lesions, we want to preserve as much vibratory tissue as possible. We can be more selective with using the KTP laser. So how do we do that? This is the laser that I use, the Aurora XP. And the nice thing about this is it's a flexible laser delivery system. The way to get it to the tissue is either through a flexible channeled laryngoscope or a transnasal esophagoscope, which also has a channel. The laser fiber is very small and can pass through there. There's also a suction port so that you can remove secretions and even disease. Well, as I mentioned, this is done in a patient who's awake and unsedated, so we have to make sure that we have good laryngeal anesthesia for them to tolerate the procedure. So the way that I get somebody anesthetized is I use oxymetazoline and tetracaine, 2% to the nose. And then I'm going to use 2% lidocaine, no epinephrine, because we're applying this directly to the mucosa, through the laryngoscope. And I typically use about 10 cc's or 10 mLs. So that's about 200 milligrams. And you want to first make sure that you anesthetize the epiglottis. The scope that we use, because it's channeled and also has a suction port, is larger than the typical flexible laryngoscope that we use just for diagnostic purposes. And as we know, we have to pass right past that epiglottis. The epiglottis is very sensitive, so we want to make sure that's anesthetized so that as we're working on the vocal folds, that more proximally our scope is not abutting the epiglottis causing gacking. That would make doing the surgery very difficult. Then we want to anesthetize the vocal folds themselves because that's where we're going to be working. And we'll do a laryngeal gargle, and I'll give you a demonstration of what that means. And then we also want to anesthetize the arytenoids. Sometimes our disease is posterior, and we could, again, just as we could abut and rub against the epiglottis, the same thing could happen with the arytenoids. The maximum dose that people use is about 4.5 milligrams per kilogram. If you use the 10 cc's, you can get people very well anesthetized, and that's about 200 milligrams in a 70 kilogram person. That is very safe. So this is an example of the laryngeal gargle. I have the patient say E, and as they say E, I slowly make sure that I drip some of my lidocaine. And you can see the lidocaine getting blown around as the person is saying E. As that air is expelled during E phonation, the lidocaine gets the chance to bathe the base of the epiglottis and my petiole, my arytenoids, false vocal folds, really getting a good endolaryngeal anesthesia. You want to make sure that you've already started to anesthetize them a little bit beforehand, because if you just drop a cc or 2 cc's very quickly, they're going to feel that and they're going to swallow, and you're going to anesthetize the esophagus as opposed to anesthetizing the larynx. So a good, slow, careful anesthesia is the key to success with these procedures. Well, how do you know when you're done with the procedure? Well, it's all about the tissue interaction between the laser and what you're doing. You'll see coagulation. You might see blanching. You can even get separation of the lesion and use the tip of the laser fiber as a dissector, having to be careful that you don't rough up the vocal fold too much and cause scarring. But these are some of the endpoints that you can use during the procedure. So here's a patient who has leukoplakia. He's had biopsies in the operating room with me before. Small recurrence. You can see the good view we get. I've already anesthetized this patient. This is the laser fiber that's coming through my channel laryngoscope. And you can see I touched the tissue there. And I've actually removed that portion of the leukoplakia in the anterior commissure. There it was, and at the end you can see that it was gone. The aiming beam is red, so you can see that. And the depth of penetration of your laser depends on how close you are to the tissue. The further away, the less depth. Here, this is not a vibratory area, so I'm going to get right on top of that lesion. And then with moving the fiber, you can see it was attached to the laser there, I can lift that lesion right off. And then I go back to that base and I can ablate that as well. My typical settings for this are 35 watts and 15 milliseconds. And depending on the disease, I can use 2 to 3 pulses per second. So again, ablate the disease, you get a little separation at the basement membrane zone, and then you can use your fiber as a dissector. This is a patient with laryngeal papilloma, and you can see what he looks like pre-treatment. A lot of disease along that left vocal fold, anterior commissure, a lot of supraglottic hyperfunction due to the papilloma. And again, a recurrent disease, an incurable disease. And so we can get in here and we can treat all of these areas of his papilloma. So again, the laser fiber. And you can get right on top of the tissue. You can see that that area, the anterior commissure, has already been blanched. And do a little bit more here to treat that. And some of the papilloma coming off on my laser tip. You can suction that off, get them to swallow that off. Again, see more ablating there. So you don't have to physically remove everything, but you want to make sure you have good blanching with the papilloma so that that blood supply has been taken away, and then the papilloma will progress usually over time. I typically see these patients back 6 weeks after one of these procedures and reassess. Again, you can remove the papilloma with your tip, use that as a dissector. And you can see here, here's the protected fiber. You do have to strip and cleave the edge of your fiber, which is this portion, so that's the active portion. You want to make sure that when you're doing this, that you see this junction between protected and stripped fiber out of your laryngoscope, because if not, if it's too close, you'll actually burn and destroy your laryngoscope and they can be expensive. So make sure that you can see that working part out. You have to do the same laser safety precautions that you do as somebody in the operating room. Everybody's wearing protective eyewear. There's mirrors in the room. You have to make sure that you cover the mirrors. I have suction active always as I'm doing this. And you have to make sure that your eyewear is appropriate for the wavelength that you're using. So this is a papilloma patient. He's now had 2 procedures and he's 5 months out from that, and you can see a much better edge to his vocal folds compared to what he had before. Better closure, and a much happier patient, and he's been able to avoid the operating room. These patients can drive themselves into clinic. We do the procedure, which takes roughly, including the anesthetic, 15 minutes. I watch them for another 10 minutes, make sure that they're doing okay, and then I let them go home. They cannot eat for 2 hours after a procedure because we've taken away all their laryngeal sensation, and we want to make sure that they have full sensation back prior to eating and drinking again. So what do we do after a procedure? Again, no eating or drinking for 2 hours. You can recheck the patient's vital signs, make sure that everything's okay. And it's important to counsel patients that the voice might be worse before it gets better. You have caused inflammation to the vocal folds, you've transferred heat, you're trying to do that in a way that is as atraumatic as possible and spare the overlying epithelium, if in the case of a disease such as a vocal fold polyp. Obviously with the vocal fold leukoplakia or papilloma, the disease is the epithelium itself, so you have to treat that. And as they're healing, it can take, depending on the degree of their disease and how much energy you've used to treat that, and that amount of energy is quite variable depending on what you're doing. It can take 3 to 5 days for the disease, for the voice to start to improve, sometimes a week or 2. So you just have to make sure that the patient can tolerate the downtime, similar to the amount of downtime, 1 to 3 weeks, with the voice rest and graduated voice use from an operative microlaryngoscopic excision. Well, who should not have an office-based procedure? If the disease was within the laryngeal ventricle and you can't see the full extent, you're going to have a hard time doing that in the office. In the operating room, you can palpate, use your laryngoscope, use suction devices, other tools to move the false vocal fold out of the way. If need be, you could even resect some of the false vocal fold to be able to get at the full extent of the ventricular disease. So if you can't see it all, then you're going to have a harder time doing that in the office. This is almost never a contraindication, but a very tight nasal cavity. Again, these scopes are a little bit larger, but I've never had somebody where you could not pass that through. If you had really bulky papilloma with potential airway obstruction, such as in that child I showed you, that would not be a good indication for treatment in the office. Somebody on anticoagulants, if you had a vascular polyp or polypocorditis that you were using, or just from the trauma of placing the scope through the nose causing epistaxis, a relative contraindication. It can be done, but you have to be careful and really assess the patient and the disease that you're treating. Somebody who's very anxious is not going to tolerate you taking away their laryngeal sensation. And you have to reassure the patient that they can swallow, they can breathe, and you're monitoring both the entire time that you're with the patient, because they're going to feel like they cannot once you take away their sensation. So if a patient cannot tolerate, because of their anxiety, of their disease, if they have COPD or whatever comorbid condition, if you're concerned that taking away their sensation will be an adverse problem for that patient, then you want to not do that. Complications that can occur, epistaxis, I have not had that happen. A vasovagal reaction, I have had that happen after the procedure. You treat it symptomatically. Vocal fold scarring, that's the most important complication that you have to worry about. So I go through the same consent like I do for my operative microlaryngoscopic excisions to make sure that the patient understands the risk to their voice. You could have an anesthetic reaction. So it's very important to monitor and always double check with your nurse who draws up your lidocaine. Make sure you see that bottle, make sure that there's no epinephrine in it, make sure they don't have any allergies to lidocaine, make sure that you are calculating in your head the amount of lidocaine that you are giving. For patients who have papilloma, initially I'll see, if it's the first time I've done this, I'll see them back at about 6 weeks to monitor their response, assess what their baseline vocal folds look like, and get a sense of what their vibratory function is. And then I usually have my papilloma patients call me when they feel like their voice is becoming dysfunctional for them. And we'll set them up for another procedure. For patients who have leukoplakia, I do interval exams, and the frequency of those exams depends on the disease pathology. Somebody who had mild or no dysplasia can follow up maybe at 3 to 4 months, whereas somebody who had severe dysplasia or carcinoma in situ is going to need follow-up every 6 to 8 weeks. And so it's very important to make sure you have a compliant patient when you're dealing with leukoplakia because of the malignant transformation risk. And we retreat leukoplakic patients as needed. So if they have disease that's returning, and the threshold of when you treat depends on both the function of the patient and how the voice is doing and the degree of the pathology. Again, mild dysplasia with a small recurrence, I might watch that for a few times and make sure that it's not getting worse. Severe dysplasia, because of the risk of malignant transformation, if they get a recurrence, and if it changes, they need something else done. And if it does not respond to an office laser procedure, then they need to go back to the operating room for a complete excision using the microflap excision technique. Certain caveats to the office laser procedures. I feel very strongly that having a tissue diagnosis first in leukoplakic patients is vital. This is a moving target, so you are not going to be potentially as precise as you will be in the operating room. Visualization and access are important, and you might find that you're using the right nasal cavity, but you can't quite get the angle you need to get some of the disease depending on its location, so you may have to use both nasal cavities. So make sure you tell the patient that. With leukoplakia, it can be hard sometimes to determine when your procedure has ended. Leukoplakia is already white, so how do you know when a white lesion has already blanched? That can be tricky. But by treating the lesion itself, and then you can gently use the tip of your fiber, you can see if you can get any separation, and if you can, sometimes you can dissect that off. And this is just a tool, just like a cold excision, just like a powered instrumentation with a microdebrider. This is a tool, so it's not a cure for the disease. So it does require careful thought and practice. I will make one comment about the microdebrider. I think it's a good technique for laryngeal papilloma. You are removing the epithelium. I do not like it and do not use it for any of these other lesions that I've shown you. I don't think you can be as precise, and we want to be precise. We want to have mucosal preservation. So regarding the office treatment, it is cost effective. There is a good treatment response. There are very good functional outcomes and plenty of data now to show that. It's less morbid. It's less inconvenient. You don't have to not eat after midnight. You don't have to take the whole day off. And it's a very valuable tool, especially for these recurrent diseases, and especially in patients who are risky for general anesthesia. That being said, it is still a fight with insurance companies to get paid, as there's not a CPT code specifically for these office procedures. When we're talking about the microlaryngoscopic techniques, this is all about surgical precision for the best outcome. And we want to preserve our mucosa. This reduces the risk of tissue loss. We want to have a three-dimensional appreciation for the vibratory surface of the vocal fold. And there's a high percentage of acceptable postoperative outcomes, and it's very reliable. Thank you.